Good afternoon, and welcome to the webinar, A Conversation with State Officials on Medicaid Dental Managed Care. This webinar accompanies the release of a new brief that is actually live on our website right now. My name is Andy Snyder, and I'm a project director at the National Academy for State Health Policy, or NASHP. NASHP is a nonprofit, nonpartisan academy of state health policymakers committed to helping states achieve excellence in health policy and practice. And we're bringing this webinar to you today with support from the American Dental Association. We have a great discussion lined up for you today. As the name of this webinar implies, this is going to be a wide-ranging conversation with some very knowledgeable state officials from across the country. Expect a little less in the way of PowerPoint presentations and a little bit more back and forth and conversation. I'm excited to get to our panelists, but first I'm going to do a little housekeeping and scene setting. At this time, all participants are in listen-only mode. We'll take questions at the end of the webinar. You can submit a question at any time by clicking on the chat box on the left side of your screen. This conference is being recorded, and the recording will be available on our website, nashp.org, within the next week. So, why are we talking about Medicaid dental managed care today? I ordinarily start these webinars by doing sort of a, it was a dark and stormy night about why oral health is an important issue, but this is a more specialized topic, so I'm going to assume that most of our audience is already up to speed on why oral health is important to care about and why it's important to overall health. But particularly with respect to managed care for Medicaid Dental Services. There was a wave of Medicaid dental program reforms in the late 1990s and early 2000s that focused on specialized administration of dental benefits in states like Tennessee and Michigan, who had a lot of success with so-called carve-out approaches. But as more state Medicaid programs have begun to use managed care to deliver health benefits to large portions of their enrollee populations, and as more states move toward a goal of integrating services like behavioral health or oral health with medical care, a growing number of states are adopting managed care contracting approaches that encompass oral health benefits along with medical benefits. There are also some really good recent resources that have been developed by the Centers for Medicare and Medicaid Services and other groups to help states take advantage of managed care quality improvement tools to drive improvements in access to oral health care. NASHP's just, so we thought this was an opportune time to jump in and explore this topic, and NASHP's just completed a detailed case study of Kentucky's experience administering dental benefits as part of a larger Medicaid managed care contract. The state adopted statewide managed care for the majority of its Medicaid enrolled population in 2011, and in a 2015 rebid of its managed care contracts, it identified oral health as one of 7 key areas where the state wanted to achieve measurable improvement. And our case study looks at the story leading up to that decision, at the current activities of the states, its managed care plans, and those plans' dental subcontractors to achieve that improvement. The brief also draws some lessons for other states in several key areas, including assuring network adequacy, managed care plans' efforts to connect enrollee to dental care, state oversight mechanisms, strategies to integrate medical care and oral health care, and strategies to drive quality improvement among MCOs by using performance improvement projects. Kentucky is an interesting case study because of its challenges with a significant burden of oral disease and because of the prioritization of oral health as a key area of interest in the state's contract rebid. But we wanted to take the opportunity of this webinar to widen out our focus a little bit and get the perspectives of 2 other states who have had a long history of managed care contracts that encompass both medical and dental care, to get a sense of how they and their MCO partners are approaching these key areas of network adequacy, connecting enrollees to care, and driving improvement. And so we're happy that we have representatives from both Arizona and Pennsylvania to join us on the webinar today. Each of our states will be providing a brief 5-minute overview of their state's approach to managed care and dental services to give you a little bit of grounding, and then we'll launch into a facilitated discussion. So let me introduce our presenters. First up is Dr. Ken Rich, who's the Medicaid Dental Director for the state of Kentucky, a position he's held since 2005. He's also a practicing dentist in a practice he maintains along with his 2 sons in Dry Ridge, Kentucky. He's been involved with Medicaid from both the policy and delivery perspective for over 40 years. During this time, he served on the Medicaid Medicare CHIP Services Dental Association, the Dental Quality Alliance, as a grant reviewer for HRSA, on the U.S. National Oral Health Alliance, and as a U.S. delegate to the International Dental Federation. And he's also served as a trustee on the board of the American Dental Association. After that, we'll hear from Jakenna Lebsock, who's the quality manager for the Arizona Healthcare Cost Containment System, or ACCESS. Jakenna oversees quality-related monitoring for Arizona's 17 managed care organizations, including quality of care investigations and quality improvement efforts. Jakenna is also responsible for management and oversight of Arizona's electronic health records incentive program. Jaquena spent 5 years working for one of the managed care organizations and now has over 4.5 years of experience at Access. She holds a Master's of Public Administration degree from the University of Arizona and undergraduate degrees in Marketing and Business Management from Johnson & Wales. And finally, we'll hear from Dr. Paul Westerberg. Dr. Westerberg is a 1980 graduate of Temple University School of Dentistry and began his professional career in private practice in the Philadelphia area, serving patient populations in both inner city and suburban locations. He earned an MBA from the University of Delaware in 1995 and transitioned to the corporate environment as a program dental consultant and then as dental director with AmeriChoice of Pennsylvania, administering Medicaid managed care programs in southeastern Pennsylvania. Moving to public service and state government, Dr. Westerberg joined the Office of the Medical Director in the Office of Medicaid Medical Assistance Programs of the Pennsylvania Department of Human Services as the Executive Dental Consultant, where he's been a Chief Dental Officer for the department since 2002. He is integrally involved in the oversight and administration of oral health services for over 2.7 million beneficiaries under the Medical Assistance Program. So as a reminder, we'll take audience questions at the end, so please submit your questions at any time by clicking on the chat box on the left side of your screen. So let's start off by hearing just a little bit from Dr. Rich about dental managed care in Kentucky. Dr. Rich?
Thank you, Andy. As Andy pointed out, we started this venture in November of 2011. It was driven basically initially by the state as a cost control measure, or at least to get costs under control. We have, as was mentioned, 5 managed care organizations. Those are medical managed care organizations, and we have 2 dental managed care organizations who are subcontracted to the 5. One has, of course, 4 of those. The other has 1. We also have, in managed care, we have 1.5 million people, our members, and we also have a fee-for-service that is population that is not in managed care that amounts to about 195,000 members. Dentistry in Kentucky is about the 5th largest program in the Medicaid organization. It is also brings with it, when we went to managed care, of course, a considerable infrastructure that had to be built to manage it, to run it, so on and so forth. We have been in the process for the last so many years of putting that together, making things run right, and making them work together. The other thing is, I would mention on that part, is when we come back to the contracts. The contracts initially were bid, these are the services we want you to take care of, and when you do so, we want you to bid the PMPM. So the contractors initially, in the initial contracts, actually came in and competitively bid for that. This time when it went around, the state defined the PMPM that they wanted to the per patient per month fee per month that they would pay, and then ask people to come in and bid on the contract. We still wound up with, like I said, 5 managed care organizations that came forward. Most of them were, I think pretty much all were the same contractors we had before. That being said, let's run to the next slide there. There you go. Our provider network. Our provider network consists of 1,100 dentists. 60. The only requirement we have for that is in the reg is that the dentist has to be available either within 60 minutes or 60 miles. There's being a lot looked at every point at this particular part of the program. For instance, what constitutes a full dentist? They're starting, if you have one dentist who has 3 offices, is that 3 dentists? So we're starting to take a look at that. I will also say that the MCOs have done a tremendous job of maintaining the provider network that they have. They have been extremely diligent in their efforts to make sure that services are covered. That That's really impressive. As we move forward, there seems to be more and more parts of the puzzle that come together. We are looking, as I said before, redefining the network in the terms of FTEs. We are looking at utilization. Presently, the utilization figures will tell us that 50% of the adults and probably 20% of the children, 50% of the children and 20% of the adults are utilizing services. That doesn't necessarily mean that everybody's getting comprehensive care, but that's about where we stand in the state today as we move forward, hopefully. The other thing that's happening with managed care, as far as I'm concerned, is we're trying to make small moves, though they may be at this particular time, but we're trying to make an effort toward moving more toward disease management and away from procedure-driven policies that determine success in oral health. This is going to be slow, but we are starting to make movements in that direction. As the other thing, when we talk about provider network, we have a dental TAC, which has been instrumental. With the amount of change that's come to the program in the last 5 years or so, it's been good to have this technical advisory committee made up of providers who can come in and give input. Those things seem to have helped. Sometimes it's very contentious. Sometimes it's more like a cat fight. But quite frankly, it's an important part of what we've come up with. Credentialing has also been a big issue. When we came in with this, whether it was the ACA that caused it or whether it was the institution of managed care, the provider network has gone through more changes or seen more changes in the way they deliver care, in the compliance burden that's been placed upon them than probably any time in history. Presently, it takes 90 working days to get a clean form pushed through our credentialing procedure at all levels. I mean, totally, we're looking at the state basically enrolling, and then we look at the MCOs to credential after that. So all that process running together is a very complicated and sometimes burdensome process. There's a lot of steps being taken to make that better, but still that's an incredible or difficult, if you will, sometimes a procedure and process to get through. Again, everybody seems to be pitching in, whether it's the providers, whether it's the MCOs, or whether it's the state, in attempting to make this better. We're looking at an online portal that this can be done through, which should save much time. We'll go to the next slide, please. Wrong one, back up one. There we go. Oversight. Oversight has become a huge thing. I started practicing dentistry in 1975, and there wasn't much in the way of audit of oversight. This has been for the profession and for the providers a real issue. We started out with RAC audits. I think everybody has been exposed to RAC audits at this particular time. We have program integrity, and we also have SAS. SAS is a statistical analysis system. It's the big brother in the sky. It's all starting to work together well, but needless to say, when you, again, are trying to implement changes of this magnitude, it can be less than a great thing to instill upon people. in the state, we have everybody looking at everybody at this particular time. I'm not sure that's a bad thing, but it certainly is a different environment that we all work in than we did work in before. The Department for Medicaid Services has a contract compliance. It's in-house. That's a division, if you will. And it's the one that will issue C8 letters of concern and caps to, mostly in this case, those go out to the MCOs. We also have a group called iPro, which does external quality revision, and they're starting to look at things like reviewing PIPs, like validation of performance measures, and they produce report cards even for providers and others. It's, like I say, it's a different environment than we were used to with fee-for-service. There was oversight in fee-for-service, but I don't think any of the fee-for-service was at this level. I think that's a pretty thumbnail sketch of what our system looks like, where we are, and I think I'll pass that on at this particular point to the next individual.
Great,
and
thanks.
we'll move from there.
And just so to tie up one thing, you said CAP there is corrective action plan, right?
Right, correct. I'm sorry, it is.
No problem. So that's good scene setting. We definitely were going to loop back to the issues that you raised around oversight and compliance and network adequacy and connecting folks to care. But for now, we are going to move on to our next bit of scene setting from Jackenna Lebstock in Arizona. Jackenna?
Thank you, Andy. Next slide, please. Just to give you a little bit of an overview of Arizona, we're currently serving over 1.8 million members, which is more than a quarter of our entire population. About half of those members are children, and that's who actually receives our dental benefit at this time. We don't currently have a benefit allowable for our adult populations. Over 90% of our population are in managed care. We currently have 17 managed care organizations across the state, ranging from long-term care contractors to behavioral health integrated care providers, and then our acute care. Then we also have a small percentage of our population that's fee-for-service, and that's our American Indian Health Plan that's run and maintained by Access. We do several different things when it comes to oral health. We have 3 performance measures that are contractually mandated, and with those, we do have minimum performance standards established, and we can do anything from requiring corrective action to sanctioning our health plans if they don't meet those minimum performance standards. We also recently completed a project with the Center for Healthcare Strategies around improving some of our oral health rates. And with that, we had a dental work group that was made up of all of our health plans or contractors, as well as subject matter experts from the community. We also require in contract that any new member that rolls on, as well as members that are being maintained, are assigned a dental home, meaning that when they become a member, the health plan is telling them this is the person that you can go to get oral health care services. And the members are free to choose a different provider if they want to, but at a minimum, if they don't want to choose someone, they know that there is a point of contact that is responsible for their oral health care. We also recently added a requirement that fluoride varnish can be provided in a primary care setting, so PCPs can do that as long as they've been trained and certified to do such, and we have a program for that. And with that, we expect our pediatricians to educate members on the importance of oral health and connect them to dental providers in the area that can provide follow-up care. And we've worked very closely with the Arizona Academy of Pediatrics as well as the Arizona Dental Association to help support those efforts. Next slide, please. Within our system, all of our health plans are required to have contracted provider networks. The way that that works is that Access registers providers. Any provider that wants to apply to be an Access provider can do so. However, our health plans have the ability to choose who they contract with. So there's no guarantee that just because you're an Access registered provider that you're actually serving members in all of our health plans. We have minimum network requirements that we monitor our health plans on to ensure that they have adequate coverage, and then leave it up to the health plans to make sure that they're really doing what they need to do. We do require our health plans to credential the oral health providers, and as such they have to report to us every 90 days the time frames for credentialing, any barriers that have been documented, and what they're doing if they see any concerns from that aspect. We do allow the managed care organizations to use a dental subcontractor. They can delegate the delivery of oral health. However, they are required to have a very close relationship with the delegated entity. Some health plans choose to maintain that responsibility at their level. Some delegate to organizations such as DentaQuest to support those efforts. We're not in every willing provider state, so just because a provider wants to serve Medicaid members doesn't mean that he or she necessarily will be allowed to. It's based on a number of factors, including quality, availability, things like that. We do offer comprehensive dental benefits for our children up to age 21, and between our Title 19 and Title 21 members, they are identical benefit packages, so we don't differentiate between the two. Just for some perspective, there's over 3,500 licensed dentists in Arizona, and over 1,500 are registered Access dental providers. And from that, right now we really do focus on using dentists to provide services to the members. It's a very, very limited scope for any type of provider, such as a certified independent dental hygienist or anything like that. Next slide, please. In regards to monitoring and oversight, we require quarterly reporting from all of our managed care organizations on a variety of performance measures, but specific to dental, on their preventive care rate, their sealant rate, their children's dental visits, which is the HEDIS measure, how they're doing with dental home assignments so that we can ensure all members have been assigned, and then oral health screenings as part of the EPSDT visits and how often those are being completed. Our rates are 36.6% for preventive care. That's an effort we continue to focus on, and then in 2015 really started focusing on the sealant rate, and quite obviously have some opportunities for improvement there, but are continuing those efforts with our health plans. And then our children's dental visits were at about 61.7% based on our last round of available data. And just for some perspective there, we do run internal data regularly. We also use our external quality review organization to generate official rates for the agency on behalf of the health plans. We have an annual plan deliverable in that all of our managed care organizations have to submit a plan specific to oral health care and dental services. And we have very specific elements that we outline in those plans that they have to speak to so that we can evaluate them each year to ensure that they're doing what we expect from a delivery standpoint. At any time we can request ad hoc reporting either from them, and we also do that internally as we're monitoring for trends across different providers across all of the managed care organizations. And then for internal data runs, we have a comprehensive data warehouse that we can pull a variety of elements and evaluate for numerous different components from any of the measures above, but we can factor in race, ethnicity, age, the geographic service area of which the member resides, and wider types, and so we use that as much as possible to really get some additional insight. And I think that's everything from a high-level perspective on Arizona.
Great, and we definitely are going to be moving back to some of the things that you raised, but I do want to hear right now from Paul Westerberg in Pennsylvania. Paul, would you like to orient us to your experience?
Yes, thank you, Andy. And next slide, please. Okay, well, Health Choices is the brand name that we have placed on our mandatory physical health managed care program that currently covers the majority of Medicaid recipients in Pennsylvania. The physical health managed care organizations provide all the medically necessary services, including dental, and they are, the managed care organizations are required to provide the basic coverage that is covered by the state-administered fee-for-service program. As far as their networks, contractually, at a minimum, they must ensure the choice of 2 general dentists accepting new patients on the urban and rural time limit travel parameters, and that there is also a choice of a dental specialist accepting new patients within the travel limits with a second choice within their zones. You will see as we look at things that Pennsylvania has a regional rollout of our managed care organizations. They function in distinct geographic areas, and so within those zones, that is how network adequacy is monitored. And behavioral health is carved out of the physical health managed care. It's also called Health Choices, but behavioral health services are not included, although the physical health organizations do cover the pharmacy, and there are different management basically at a county level for behavioral health services. Next slide. These are some milestones of the history of the Health Choices program. It has a long history. The 1986 pilot program in South and Southwest Philadelphia was called the Health Pass program, but in February '97, Health Choices came into, as I say, we have a geographic rollout, and the Southeast Zone was the first rollout, which included Philadelphia and the 4 surrounding suburban counties. We moved then to the Southwest Zone, which is the Pittsburgh area. 10 counties contiguous or related to Allegheny County in western PA were brought into the program, followed by October 2001 when the Lehigh Capital Zone, which is the Harrisburg, York, Lancaster area, and then extending into the Lehigh Valley out toward Allentown. 10 counties were involved there. This remained rather stable as there were issues. There were intended to be 7 zones originally in Health Choices, but we are now, as we moved into 2012, July, we finally got to expansion much past what was originally envisioned to happen by 2007, but in 2012, the Southwest Annex, 4 counties moved into the Southwest Zone, and 3 counties moved into the Lehigh Capital Zone. October 2012, the northwest area of the state, the new West Zone was created, which is the Erie area, and the the new East Zone was created in March 2013, which then put the physical health managed care statewide as of March 2013. And again, all dental services are included and covered by the physical health MCOs operational in Health Choices. We have both adult and pediatric dental services in Pennsylvania. Next slide. And so currently there are about 2.75 million people eligible for Medicaid medical assistance in Pennsylvania. About 2.2 million of those, approximately 80%, are in the Health Choices delivery system. There are 5 geographic zones and 7 managed care organizations in total that are involved in the program. You can see from the chart there that in the southeast, that is our largest zone. That's the Philadelphia area. So population-wise, southeast with their managed care organizations manage close to 800,000. 798. Southwest, the Pittsburgh area is was the next to roll out. It is currently 3rd in population at about 462,000. The Lehigh Capital area has 473,000. And the New East and New West are more rural areas in the northwest and northeast parts of the state with 159,000 and 300,000 respectively. And the statewide total in managed care 2.2 million approximately. Next slide. So this is a geographic representation. We have a map here of Pennsylvania showing what basically was the configuration of managed care pretty much from 1997 through 2012. The green and gray areas represent the mandatory managed care of health choices. The purple area is where there was both fee-for-service and voluntary managed care active in those portions of the state. The white area was fee-for-service only. There was no voluntary managed care at any point. The pie chart represents how this was broken up according to population. The Access Plus program was operational in the purple and white areas of the state in this time frame, which was a primary care case management directly contracted vendor with the state fee-for-service program, was not managed care but provided on the medical side some primary care case management services. Next slide. And this is a current representation of Pennsylvania's managed care program. Again, the blue area, Southwest, the Southeast zone, the brighter orange, the salmon color is the Lehigh Capital Zone, New East is the yellow-orange, and the green is the New West. And you can see that, again, the vast majority of individuals in the pie chart represented in blue are in the Health Choices delivery system. The fee-for-service entity, which is still directly state administered, in the red, approximately 560,000 individuals. And then this has been operational for about the past 3 years. March of 2013 was the statewide point where managed care in a mandatory fashion was in effect in Health Choices. Next slide. So, however, we are not standing still as far as managed care is in existence within the state. That the majority of those remaining in the fee-for-service state-administered program in Medicaid will be moving to managed care beginning in 2017. About 560,000 individuals, as we saw in the previous slide, or 20%, are currently remaining in that traditional fee-for-service program. And they're comprised primarily of adult dual eligibles. Most of them are, most people who are in nursing homes, temporary categories such as spend down, health insurance payment program, etc., are still under the fee-for-service directly administered program. However, most of these remaining eligibles will be moved into a managed long-term services and support known as community health choices within 2017 through 2019, and the community health choices benefits will also include dental services. However, there may be some additional managed care organizations that will be contracted. Next slide, please. So, as far as our provider networks are concerned, both in dental and on the other physical health delivery systems, they are overseen by the Department of Human Services and the Bureau of Managed Care Operations, who has that oversight responsibility. Now, the Bureau of Managed Care Operations has developed a provider network reporting solution that does provide us a standardized mechanism and format used by all MCOs to submit provider network information to the Bureau of Managed Care Operations. And so the network analysis looks at geographic radius for urban and rural settings, and there are comparison activities, and these include calls to provider offices and other monitoring methodologies that we use to continue to look at network adequacy as far as the ability to provide services. While there is a minimum contractual geographic responsibility, we do expect that the MCOs maintain networks that are adequate to fulfill all medically necessary services that their membership requires. And so that's the much higher bar to cross than just the minimum geographic requirements. So Again, our managed care organizations have the ability to work with a dental benefit manager. The majority of them do work with a national or regional DBM. We do have a couple of our MCOs that work in-house with third-party administrators for claims processing and credentialing purposes, but they manage their networks with their own provider relations. And so currently there is somewhat of a diversity between what our plans are able to do individually. But next slide, please. And this is if additional information about the Health Choices program or anything within the medical assistance program in Pennsylvania is requested, this is the web link that will get you to the DHS webpage, and with a good search engine there, you can pretty much find a lot of information online, but we'll certainly be interested in answering any questions that the audience may have today. Thank you.
Great, thank you so much, Paul. And so we're going to move into our facilitated discussion now, and since we're a little bit behind where I expected to be, I'm actually going to skip our big broad scene setting question and move directly to the question on network adequacy, since that's come up in each of your presentations. So I heard a couple of things in the presentations about network adequacy. Kind of, Ken, you raised an issue about out of the 1,100 dentists in your state, how do you count dentists who are participating either in multiple plans or in multiple locations? And there also have been a couple of questions about who at the managed care organizations or their subcontractors are keeping an eye on this. Is it dedicated dental staff that are doing that, or is it other kind of contract compliance staff? And I wonder, maybe, Paul, we could start with you just to talk a little bit more about assuring network adequacy. What are you finding to be sort of your most useful mechanisms for doing that, and is that primarily a function of the MCOs or of the specialized subcontractors that the MCOs are using?
Well, most of our, as I said, most of our MCOs do use a dental benefit manager, and in those situations, which is the majority of the cases, the dental benefit manager supplies the network. The MCO is not involved with the provider relations, that is the DBM. And but we do have a couple that actually have contracted directly with their dental provider networks, and so they have that oversight as well. But we, at the state level, the Bureau of Managed Care Operations is responsible for overseeing the MCOs and ensuring that their provider networks are adequate to provide services to our citizens. So it's a shared responsibility that the DBMs are charged by the plans in their subcontracting relationship to provide the network, but we at the state level take the responsibility to monitor that as well. The MCOs, again, our Bureau of Managed Care Operations has developed a proactive program that monitors the access to care for those recipients in the Health Choices program. And it was developed, this proactive program was developed in line with the Office of the Inspector General's report, which was entitled Access to Care, Provider Availability in Medicaid Managed Care, and which had been issued in response to a congressional request to evaluate the access to care for enrollees in managed care. And this network analysis portion of BIMCO's program looks at the geographic distribution of the MCO's enrollees and determines the number of providers a recipient has access to within the certain geographical radius, and then network gaps, if they are identified, for recipients not having two distinct provider choices within 15 or 30 miles, depending on urban or rural. Those things are addressed with the plans and with the DBMs. And also, the BIMCO staff compares network information submitted by the MCO with additional provider directories and other information that's supplied to our enrollment broker which is involved in the actual transition of incoming recipients and their selection of a managed care plan. So a variety of points of information are reviewed continuously to determine network access.
Great. And so, Ken, maybe we can go to you next. I know that in the 2015 contracts in Kentucky, the kind of access standard, the geo access standard is 60 minutes or 60 miles. And I wonder if you could talk a little bit about kind of what your sense is of how the MCOs and their subcontractors are enforcing that, what seems to be the most kind of useful tool you've got to check in on that, and also kind of whether there are any particular areas of concern for you. I'm thinking maybe like specialist care.
Yeah, they have worked hard, and because there's some areas in Kentucky that I'm not sure it's even possible to do that because of there are very few areas, but there's like 2 in the state that make that very difficult. And for the most part, the MCOs have done a great job of taking the resources that are available and making them function. It is interesting, though, to me that at least somebody is starting to look at the definition we're using, and that doesn't mean that we've changed anything because the contracts are still the same, but at least they're starting to explore the possibility of what we really need as an adequate workforce load in those areas. They have managed. I know there's been one case of a managed care organization a while back that actually came out of their managed care fees that they were paying and actually worked with a contractual basis on one oral surgeon. So they have done, in many cases, what needs to be done to see that care can be provided. But other than that, that's about as far as we've gotten. Whether there will be some sort of an FTE thing that's developed or what, I don't know. Like I say, they're in the very early stages of starting to look at that.
Okay, great. And Jakenna, do you have kind of thoughts about assuring network adequacy in Arizona, particularly with the large number of MCOs and subcontractors that they use? Kind of how do you look across all of that and determine whether you've got enough dental providers to meet the needs of your enrollees?
So we do a couple of different things. I think I mentioned earlier that we do require network adequacy reports each year from our contractors, and we have very specific standards that they have to evaluate that we then do some cross-checking on when those are turned in. Another thing that we do are secret shopper surveys. We will pull up the contractors' provider listings on their websites, and then we'll make random calls to see how quickly we can get in for services, to see what kind of feedback we get when we do those calls. And we've done that for the last couple of years, and it's been very insightful. It's usually a random sample of 30 providers across each of the plans, and if we have any deficiencies of the feedback we receive, and then require our health plans to complete corrective action plans to ensure that any barriers that we've identified are assessed. So those are some of the major things that we really look to. And then anytime from a quality perspective, probably the benefit of managing the quality improvement and quality management components together is that if we get any concerns about availability, accessibility, things like that, we will definitely work those investigations and then take those findings and apply them to a more systemic improvement for our system. So we're continually evaluating that as well.
Great. And I think looping back to one of the remarks that you had made about looking at number of dentists being sort of your primary gauge for network adequacy, there have been a couple of questions about other kinds of providers in the dental space, either registered dental hygienists who are in public health practice or some other sort of extended practice, or school-based sealant programs. And I wonder, this is open for anybody, if those sorts of providers enter into the consideration either at the state level or with your plans for kind of the number, the adequacy of your provider network out in your states?
So from an Arizona perspective, our school-based programs are pretty small. So we try and support them as much as we can, but with that said, it's a very, very small population that is served, so we don't consider them to be an option. And then with registered dental hygienists, we have a very, very narrow scope in Arizona. So for our ongoing preventive care and things like that, unless they're meeting very specific requirements, they're also not considered a provider that we work with at this time. So it's a very limited availability in Arizona.
And Andy, for Pennsylvania, we do have a mid-level provider at the public health dental hygiene practitioners, but they're currently not given a separate provider type independent of a dentist in the Medicaid program, except as they would function within FQHCs. There is a funding stream for them through federally qualified health centers. But generally, we look at dentists as far as network adequacy.
Great. So there were another set of questions that came in while we're talking about providers, and we'll go ahead and ask this now. Payment rates to providers. What's the sort of role for each of you in a kind of state capacity with either monitoring or having involvement in the rates that are paid to providers? Is there any? Maybe Ken, we could start with you on that.
Yeah, unfortunately, I'm not sure we have anything written down. What did happen recently, or what we go by so far, is the states and their fee-for-service fees. We actually increased those this year, and at that particular time, the MCOs followed suit with most of those fees, if not all. It's really difficult. I don't know what other states do, but it's very challenging when medicine, of course, is uses as a baseline or as a comparison Medicare, and dental really doesn't have anything like that. So it's still not as good as it could be by any stretch of the imagination in Kentucky. Would love to see something that, if anybody else has got an idea, would love to see something that we could tie this to that would be more consistent than what we're doing. It was the first year in quite a while, since 2005, that we were able to raise some of the fees in Kentucky, though.
Paul, I don't know if you've got a sense from Pennsylvania about sort of your role in either overseeing, or if there is a state role in being engaged in what the managed care plans in Pennsylvania are paying their network providers?
Yes, well, the Health Choices program, as I imagine many of the other managed care delivery systems, it operates under a 1915B waiver authority, and under that waiver authority, the fee schedule for the fee-for-service program is actually waived for the managed care organizations. But that adds flexibility as well, that they are allowed to individually contract with dentists rather than having a one-size fits-all or none type of an arrangement, which the fee-for-service program is mandated under the Medicaid program to have equitable or equal payments across the network. So they can look at individual providers, provider types, those that bring special things to the table or whatever, and adjust. Now, it's a two-edged sword because they can adjust upward or downward. I think we have instances where we are made aware, although, again, providers are not, the dental associations or whatever are not able to price fix as well. And neither are MCOs price fixing between. So competition within the zones between MCOs and DBMs and all the other factors, it's somewhat of an open market. And again, the overriding factor is that we monitor for adequacy. If they have the correct or the ability to provide their services to their membership, and we certainly monitor consumer complaints or other situations as far as access to care, then we are not involved in individual provider negotiations, but we do monitor and take into account feedback that we get from stakeholder groups and other things about. And so I would say that there are instances where the MCO is paying individual providers above what the fee-for-service fee schedule is, and in some areas where they have a lot of dentists, it may be that there are prices at or possibly less than what the fee-for-service fee schedule may dictate. So.
Okay. So we're moving quickly through our allotted time. We got about 10 minutes left. I do want to take a quick stop in to answer some of the audience questions here on the topic of connecting enrollees to care, and how are you assuring utilization of care by folks that are in the program. And there's two things particularly that audience folks have raised that I want to get a quick read on if we can. One is, do you have any sense about whether there's been sort of a net positive effect from administration of dental care through managed care contracts, through integrated managed care contracts, in terms of use of services? Like, can you tell whether there's been a positive effect there? And two, one of the things that we saw in our work in Kentucky was that the kind of care coordination part for connecting enrollees to care sits at the MCO and not at the dental subcontractor. And I wonder if if folks have a sense about whether that MCO care coordination capacity has been useful in getting enrollees into care. And maybe, Ken, we can start with you.
Sure. Let's see. First of all, with the care coordination issue, at least it's entering into conversations, especially with the medical directors meetings that we have. We have a monthly medical directors meeting that includes the dental. And it's become a topic at that level of how we can move forward. We haven't implemented anything at this point, but there was discussion a while back about the issue of possibly dentists doing a glucose level testing in their offices, things like that as we move forward. Again, it hasn't been put there yet, but for the first time since I've been around, we're at least starting to explore those kinds of possibilities. I think that that has some merit as we move forward. The other thing is, a lot of the reason that we can't seem to make impact in certain areas or certain populations within the state has to do with cultural issues. And a patient navigator type thing or entity makes a lot of sense. And I don't know that we've seen a lot of that used. I know we haven't seen a lot of that used in dentistry. But with two entities that are evolving in the state, one is a public health hygienist and the other the potential for a community dental health coordinator, we may be at least moving in those directions. Does that address your question?
Yeah, it does. And I'm actually going to move on here because we're down to like 5 minutes or so. And I want to make sure that we loop in Jakenna, just from your perspective as being a quality improvement manager and not a chief dental officer like our other two speakers. There have been a set of questions about quality improvement and quality measurement. And I wonder, from your perspective, could you talk a little bit about whether you've encountered any challenges in kind of thinking about quality in the dental space since that is a newer conversation to dental land than it has been for medical care, and also what you found to be useful tools to drive quality improvement. And also there was another question about the 3 performance measures that you're using, and if you could just say what those 3 performance measures are.
Sure. So from a quality improvement standpoint, we found it's absolutely critical that you have stakeholder buy-in. And for Arizona, that starts with our managed care organizations and also our provider community, as well as the other subject matter experts across the state and the professional organizations and things like that. We promote a very transparent process about the measures that we have contractually mandated for the contractors. We share what those discussions are. We invite them to the table as we're working through initiatives. And I think, again, getting that buy-in, getting that feedback, sometimes it's taking a state-level approach that regardless of which contractor you are, this is the effort that we're going to outline to promote oral health. Having that unified front as a health system versus an individual provider or an individual contractor is really helpful. The measures that we focus on, we do the HEDIS measure, the children's dental visit. We also do preventive care. We use a CMS 416 form to determine our preventive care rate, looking at those that receive preventive care that have been eligible for greater than 90 days. And then the measure that is new to the CMS children's course set this year around sealants for those members or those individuals that are at risk for caries. And so we definitely try and align our measures with national measure sets, what's of interest across the country. We do a lot of coordination with CMS to ensure that what we're focusing on is what they're deeming to be an important focus for Medicaid generally. And I think that's really important to definitely look and see what's occurring. Probably because we've had performance measures in our managed care system for at least the last 20, 25 years, if not longer. It's not a new concept to our health plans, and so that really helps because if you're newer to managed care and starting to just put some of those in, there's definitely going to be probably some initial pushback. And with that said, we get pushback from time to time with our contractors as well. So it's ensuring that you have mechanisms in place that you either positively reward or negatively reward behavior. So, for instance, we do both. They can either get a percentage of their capitation back if they perform well, and if they perform poorly, we can sanction them up to $100,000 a measure. So really incentivizing that performance is also important.
Great. So we are down to our last couple of minutes, and maybe we can just spend 1 minute apiece, and do try and discipline yourselves on that, thinking about the big broad question about taking all together everything that we talked about. What do you think are sort of the big upsides or maybe big challenges to taking this approach to from your state perspective, to administering medical and dental benefits together under a single contract? And maybe, Jakenna, we can start with you.
So I think probably the biggest concern is just when we try and manage it and the method in which we do it, our health plans do have the ability to make business decisions based on their unique needs. And so with that then comes some frustration from our providers about, depending on which health plan they're working at, there may be some different requirements that they have to meet. So I see that as being a challenge. But we also see that, allowing the health plans to know their membership and their networks and the areas in which they serve is a benefit. So we try and balance that out with the different mechanisms we put in place. But overall, I think that, if you have the appropriate structure put in place, it really can be an effective mechanism for delivering care. So it's just being mindful of what the providers are facing and being responsive to them as well as to the health plans.
Great. Paul, 1 more minute on big opportunities, big challenges.
Well, I think the opportunity with managed care is the flexibility that working under the federal waiver brings, and then with that flexibility of provider contracting allows for tailoring of what the, as Jakenna had said, individual prioritization based on geography and other situations can help there. And the state also accrues the benefits of multiple perspectives and approaches when it comes to addressing issues, because some of our MCOs and their DBMs bring a national perspective which you wouldn't get in one program. So it allows for that. That flexibility, though, also leads to the drawback side, as Jakenna had mentioned, the credentialing and different policies between does put some pressure on provider networks, but again, it's incumbent on the state program administration to assure that the autonomy and flexibility that's afforded to the MCOs is being properly exercised and in accordance with the applicable state policy. So that's enough for me.
All right. Ken, we are right at the top of the hour, so you get the last word.
It might be a word. I have to agree with what the other two speakers have said. I think the biggest thing I see is the pressure put on the traditional delivery systems, the private practice. That is becoming more and more an issue. I think that the private practice, or even, whatever the delivery system is, it's going to have to change as we move forward. The compliance burden just continues to increase. The fees, of course, are not going to be anywhere close to what private practice looks like, and or fee-for-service looks like. And I think those will be the biggest issues, and I think that both of the other speakers expressed that same concern as one of theirs too. So I'll stop there.
All right. Well, that is where we will leave it for today. So we want to thank once again the American Dental Association for making this webinar possible. Thank our panelists, Dr. Ken Rich, Jakenna Lebstock, and Dr. Paul Westerberg, and thank all of you for attending. If you want to learn more, NASHP's new brief and an archive of this webinar will be available on NASHP.org, and also check out the resources from CMS and the Centers for Healthcare Strategies listed on this slide. You can also contact me at the email address listed here, and please join us for our annual conference October 17th to 19th in Pittsburgh, Pennsylvania, for 3 days of content on a wide range of health policy issues. Following the webinar, you will be directed to a brief evaluation. Please take a moment to complete it. It's the only way we'll learn. We value your input and feedback. Thank you, and have a great afternoon. This concludes today's webinar.